Okay, all right, proceed.
Right, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So, okay, I'm gonna continue with last week's questions about nebulization and aero chamber. Okay, next slide, please. Okay, so nebulization and aero chamber. It's basically it's used for inhaled medication, right? So for inhaled medication, we need to look at the indication and the contraindication, or this little bit misalignment there. Okay, so for indication, it is for the administration of medication to the lungs, and for contraindications, it can be absolute or it can be relative. So for absolute, if there is any allergy reaction to the medications, and relative contraindications, if we found out that there is an anatomic abnormalities that causes increasing symptom with treatments, which means that it become more worse. It become worse, then it is considered as contraindication. Next. All right. So for patient preparations for nebulizations, so most children who require inhalation medication for breathing will be stable. They will be stable enough. So children with severe bronchospasm or hypoxia should be placed on a cardiac monitor as well as pulse oximeter. And sitting upright is preferred. And young children should be held by their caregiver to comfort them and to make them feel safe. Okay, next. So you must be wondering what is a nebulizer. Okay, so a nebulizer is actually a machine that converts liquid medication into fine mist that is inhaled into the lung. So in other we can understand that a nebulizer pushes compressed air or oxygen through the liquid medication, and it will convert into a mist form. Then the mist will be inhaled through a face mask or a mouthpiece. So as you can see on slide, parts of the nebulizer. So nebulizer can, nebulizer can be comprised of the compressor, the tubing, the nebulizer cup, and as well as the mouthpiece. And some might use a face mask as well. Okay, next. So this is basically a few, I listed a few indications to use nebulizer. So nebulizer can be used if it is prescribed by the medical practitioner. It can be used to treat or control persistent infections. We can administer antibiotics, and drug required is not available in an inhaled preparations, or it can be used before physiotherapy to loosen secretions. Used for child with stridor, respiratory distress, acute asthma attack, and it can also be used to treat infection in children with cystic fibrosis, and used before physiotherapy, especially at home. So these few indications to use nebulizer in particular. Okay, next slide. So what is actually delivered? So it's as you can get is medications and solutions, both combined. So for medication can be bronchodilators such as salbutamol, steroids, antibiotics, and it can also be adrenaline. And then as for solution, it can be normal and hypertonic saline. So this is the delivered substance in the as we use nebulizer. Okay, next. So how to use nebulizer? Okay, first and foremost, we need to provide power to the compressor, to the nebulizer machines, be it electric or battery powered. And then we attach oxygen tubing to the compressor and attach the nebulizer cup to the free end of the oxygen tubing. Okay. Then we open the top of the nebulizer cup by twisting and lifting the cap. We pour medication into the cup and we reattach the top piece. Okay. Then we have patient put the mouthpiece in the mouth we still mean by lips, or if the patient is using mask, then place it on the patient face. Then we turn the machine on, and then we instruct the patient to take slow, deep breath until the mist is stopped. Okay, and then finally we turn off and clean. And then we go to the part of how to clean the nebulizer. So on nebulizer chamber, usually leave a residual volume of between 0.5 to 1 mils. So the nebulizer is disconnected from the flow meter and the tubing. So the nebulizer chamber is taken apart, and the three components, the composition parts of the be it face mask or mouthpiece, the top piece and the cup that I mentioned. And then any residual solution is discarded. So after that, the three components are washed with warm soapy water or mild detergent. And then after we wash all that, we rinse all the three parts and dry with paper towel. And then the tubing and the chamber, in other hand, should be discarded if discarded stickiness or the chamber is cracked. So the pump, the compressor itself must be serviced every 6 to 12 months, depending on the conditions. So filter must be checked and cleaned and replaced regularly. So this is basically the general idea of how to clean the nebulizer. Okay, all right. So first part about the nebulizer is settled. Then we move on to the aerosol chamber or the spacer. So what is an aerosol chamber? So it is actually a plastic container designed for easy delivery of asthma medication in the form of aerosol from the metered dose inhaler. So it is to facilitate. Next. So these are two example of spacer. One with spacer with mouthpiece, and another one is a spacer with mask. Okay, next. Okay, so how to use it? As you can see from the figure I attached. So first and foremost, we have the metered dose inhaler. We take the cap of the inhaler. Then we shake.
Boleh go back to the slide tak?
Yes.
Go back to the previous slide. Okay, I just want to show you the aero chamber at the far right, yang warna purplish sikit. Ada white, ada purple tu. Nampak tak? Ya, okay, yang you tunjuk yang purple dekat ujung-ujung dia. This one yang brand aero chamber lah. Yang kanan sekali, kanan. This one. Yep, that one. So this one is Philips Respironic Opti Chamber. Dia ada banyak brand lah. So ini is Philips Respironic Opti Chamber. I just want to show you, yang ni kan, if you buka dia punya mask tu, dia jadi mouthpiece. So this one is very good sebab dia ada mouthpiece sekali, built in. Lepas tu kalau you tengok juga, you boleh nampak ni, dia ada spacer ni, valve dia tu is circular. Bila valve dia circular, dia ada banyak area yang boleh expose. Tapi yang Philips ni, you nampak ni, dia punya valve tu, you nampak ada macam triangle sikit, macam piramid tu. So this is why aero chamber yang lain, bila you breathe kan, you can suruh patient breathe 10 kali. But this one 5 times is enough sebab dia punya valve tu sikit, small, and so drug delivery is a bit better and it's cheaper as well. Dan dia contohnya bila budak tu kecil dia pakai mask, bila budak tu besar dia just boleh cabut mask tu guna as mouthpiece. So this one is more cost effective lah if you ask me. Alright, fine, proceed.
Okay, so back to how to use it. So we have the inhaler as I mentioned, and then this inhaler we attach to the spacer and take the cap off the spacer. So the child, we need to ask the child to breathe out all the way, and then we ask the child to close the lip around the mouthpiece. Then press down the inhaler, and then the child should breathe in slowly and deeply. Okay, and then the child or our patients need to hold the breath for 10 seconds, and then they need to breathe out slowly. So this is the process needed. So if the patient needs another puff of medicine, they can wait for 1 minute, then repeat the steps 5 to 9 like the picture shows. Okay. After completing uh, the inhalation of medication, then we ask the patient to rinse out and spit out the residual medication. Okay. So as you can see on the right side, there's a description of the spacer with face mask and spacer with mouthpiece. For the spacer with face mask is for covering the mouth and nose and completely sealed, but not too tight. As opposed to the mouthpiece, it is spacer between your teeth and it close lips tightly around it. So that's basically the description for both type of the spacers. Okay, next. So reach to the part of how we can clean the spacer. So the effect of the detergent coating on electrostatic charge on the spacer diminishes within 1 week. So here, why did I mention the effect of detergent coating is basically because the detergent that we use to clean the spacer can help to improve, or it can help to improve the level of drugs in which it can reduce the electrostatic charge available on the spacer. So if so, the electrostatic charge that on the spacer will interfere with the drugs delivery. So if the electrostatic charge is reduced, so the drug can be delivered more effective. Okay, how you can get it. So it is the importance of cleaning spacer. I want to convey here. So what you can do, okay, what you can do it can be cleaned once a week with warm water and with mild cleaning detergent. Then it should be dry naturally within room air. And do not microwave the spacer to dry it. And we need to be cautious not to rub the internal surface of the spacer with a brush or cloth, as it may damage the surface. It will reduce the efficiency of the drug delivery. And then do not use hot water to clean the spacer or harsh detergents such as chlorine. So I did attach a link of how you can clean, and then if you have the time, you can go and see it for yourself. Okay, next. So for complication of both the nebulizer and electrolyte, it is basically it is caused by the drugs, but not the method of delivery by itself. Among the complication, it could be bronchoconstriction secondary to the preservative available there, and it can be tachycardia, arrhythmia, agitation, and it may be oral candidiasis depending on the drugs which are used. And then next. Okay, so as for the monitoring and follow-up of our patients, so for monitoring, so children in acute respiratory distress symptoms such as those with respiratory rate increase, wheezing or infection. So the patient need to be assessed before and after the administration of medication to see whether after the administration the patient improve or it get worse. And as for follow-up, so for follow-up it depends on the need of the use of inhalation medication for asthma, for example. So children with acute wheezing, follow-up should be 1 to 7 days after the intervention. And for if the disease is stable, then follow-up of every 3 to 6 months is actually adequate. So well, it depends on your personal assessment of the child, whether how long it need to be followed up and monitored. Okay, I think that's for my part. Any question from the group?
Okay, one thing I want to say, another one important factor for the delivery of drugs through respiration by so basically by aerosolization. So this procedure is what we call as aerosolization. So aerosolization is basically is aerosol generating procedure. So it produces aerosol. So this aerosol is the one that gets into the lung. There are several factors that helps in aerosolization. The first one is the flow. Contohnya kalau kita pakai ventilator kan, flow of air tu pushes the aerosol in. Itu satu. Yang kedua is actually the size of the particle. So this is important as well. For example, kalau you bagi nebulizer, kalau you set flow dia rendah, macam 4 liters per minute ke apa kan. So the issue is bila flow dia rendah, dia punya particle size by nebulizer tu will be big. The smaller the particle, the farther it will go inside the lung. Partikel besar dia pergi dekat saja. Sama juga dengan MDI. Inhaler. The bigger the particle, lagi banyak dia akan deposit dekat throat, deposit dekat trachea. The smaller the particle, the better it goes inside the lung. Contohnya kalau you look at if you look at different types of inhaled corticosteroids, fluticasone, flixotide, nama dia ubat tu fluticasone propionate. Dia punya nama brand dia is flixotide. So yang warna purple tu. So flixotide ni bagus dia adalah is nanoparticle. Particle size is very small. So it gets into the lung. Dia expanded inside the aerosolized ni lama. And then it gets well into the lung. Tapi if you look at ada older punya ICS, older inhaled corticosteroid, contohnya betamethasone atau beclomethasone. So beclomethasone ni particle size dia besar. So bila particle size dia besar, sometimes bila dia guna, dia akan rasa dekat belakang tekak dia. Sebab apa dia rasa dekat belakang tekak dia? Sebabnya the particle size is big and dia deposit dekat belakang tekak dia and risk of fungal infection and so on and so forth. So particle size is very important. Also remember juga, yang ini kita just tunjuk pada you are using nebulizer dengan spacer. Tapi dia ada banyak lagi cara macam mana you nak bagi inhale device ni. For example, you boleh bagi DPI. DPI ni apa? DPI is dry powder inhaler. Kan? Yang kita guna dengan spacer ni, kita guna metered dose inhaler. So metered dose inhaler ni sebab dia ubat tu dia suspended dalam dia punya chamber tu kan. So dia bagi macam tu. Tapi ada satu lagi cara adalah kita guna DPI, dry powder inhaler. So dry powder inhaler juga dia ada banyak cara dia punya bentuk MDI dia tu, device dia tu. Ada yang jenis you nampak macam bulat. Bentuk macam bulat. So bentuk macam bulat tu nama dia adalah turbohaler. So turbohaler dia ada turbohaler budesonide, nama dia palmicort, ataupun dia ada turbohaler terbutalin. Terbutalin turbohaler. Ataupun you nampak yang jenis yang rupa lebih kurang sama macam inhaler MDI ni, tapi dia klik. You klik sekali, lepas tu you sedut powder, small particle powder. Contohnya macam yang ni ada beclomethasone. Dia panggil ni easy haler. Dia ada easy haler. Dia ada juga yang jenis kita panggil sebagai AccuHaler. AccuHaler ni you tengok device dia bulat macam cengkerang, so dia pusing. That is AccuHaler. Dia ada macam-macam jenis device. So these are things yang you need to know. Again, usage of spacer ni pernah masuk exam twice untuk OSCE. Untuk OSCE yang unmanned OSCE tu kita boleh just letak satu gambar aero chamber kat situ atau letak aero chamber situ, mention apa benda ni. Surprisingly your seniors ramai tak kenal pun tu adalah aero chamber. Atau at least kata spacer device pun ramai tak cakap pun. Ramai tak kenal pun benda tu. Kita juga pernah buat untuk man OSCE punya session kan. Kita pernah buat kita suruh kita bagi device ni dan ada satu pelakon yang menyamar sebagai parent counsel macam cara nak guna. And again, many of your seniors did very bad. Okay, alright, proceed.
Okay, Assalamualaikum. My name is Amira. So you can hear my voice? Okay, so I will be presenting about central line procedure. Next. Okay, there are three, which is peripheral inserted catheter, femoral vein, and jugular vein. Next. So this is an overview of what I will be explaining to you. Basically, the procedure is quite similar. The location is different. Next. Starting off with the peripheral inserted central catheter PICC, it is a catheter inserted usually in the basilic or cephalic vein at your cubital fossa, as you can see in this picture, and the tip resides in the superior vena cava. Next. The indication basically PICC is for those with limited peripheral access, for you intermediate or long-term therapy such as drugs, infusion, chemotherapy, and you want to administer drugs or fluid. And it is also used for nutrition, which is total parental nutrition. For the contraindication, PICC we cannot do for patients who have thrombosis, any infection at the insertion area, clotting factors, positive blood culture, and also patients who have symptoms of persistent cough and also vomiting, because this could increase the intrathoracic pressure, which can lead to catheter malposition. Next. Now I will explain to you about the types of PICC. As you can see in this picture, there are three types: single, double, and also triple lumen. The component is next. All right, so this is what you will see if a patient have PICC. There will be dressing, the white surrounding the cubital fossa, the line or lumen where you can insert drugs or fluids. They also clamp, securement device, and also form this with medicine. Next. For the catheter, we must know the size of the patient catheter. So basically the measurement is in French. 1 French is equal to 1/3 millimeter. So it shows the diameter of the catheter. Next. For a patient in pediatrics, we must know the correct catheter that is suitable for him or her. So it is based on the age, the weight, and also the site of the selection. Usually, the size we use in neonate is 1 French, and for the infant we use 1.9 or 2 French, and we rarely use above 4 French because the lumen will be too big. Okay, next. So let's watch the procedure done in PICC.
Boleh dengar ke?
Boleh, boleh. So we prepare the equipments first. So first you do an ultrasound at the upper arm to evaluate, and then you eject lidocaine for local NS. You insert 21 G 4 centimeter needle inside. Followed by guide wire under fluoroscopic guidance. After that, you remove the micropuncture needle. And make a small incision. Make sure the PICC tip location is at the entrance of right atrium, which is the superior vena cava. You insert the PICC catheter. Remove the peel and wire. Inject the heparin lock PICC with 10 units solution. And lastly, you secure the placement of PICC and apply biopatch and dressing. Okay, next. So after the procedure done, you must ensure that the catheter is at the correct place by doing an X-ray. If you do it for the upper limb placement, which is through the cephalic vein through the at the cubital fossa, make sure the it is at the superior vena cava above T4. Since PICC can do at other placement, if you do it at the lower limb placement, make sure the catheter tip is at the inferior vena cava, lower to T9. So make sure that that there is no misplacement, such as loops or buckling in X-ray. There's no malposition to cardiac chamber, internal jugular vein, and also the subclavian vein. Next. The complication of PICC, patient can have thrombosis, phlebitis, catheter malposition, damage, occlusion, and most importantly, if you insert too deep inside the right atrium, the patient could have cardiac arrhythmia. And remember, last but not least, PICC care. You must not disturb the insertion site with the tegaderm. Flush each line every 24 hours, and every 7 days, change the IV connector, change the dressing, and take antibiotics. This is to prevent further infection at the injection area. Okay, next. All right, the second one is femoral vein. As you can see in the picture, the catheter is placed at your femoral vein, this is the most common access central line in pediatric resuscitation. Next. For indication, is quite similar. However, this procedure is important in patient who is seriously ill, ventilated pediatrics, and who is have difficulty in vein access, and important in emergency resuscitation. Femoral vein is common also for you to take frequent blood draws. However, the contraindication is similar to the PICC, and it is important that a trained doctor do this procedure. Next. The procedure, first you prepare the equipment as before, such as sterile set, cannulation. You prepare solution for the patient, such as the iodine, lidocaine for NS, and then also the sterile dressing. Next. To proceed with the procedure, you must first ensure the position of the patient. As you can see, the patient is lying in supine, and you raise the hips of the patient so you can get a clear anatomy of the patient. Either you place a towel at the bottom of the buttock, so it is raised a little bit. Okay, next. Now, you must position and know your landmarks for femoral vein. As you can see, there are two pictures. First, the femoral anatomy, and second, the femoral landmarks. So based on the picture femoral anatomy, the femoral vein is located medial to the femoral artery. So how can you determine the landmark of femoral vein is by, first, you need to locate the femoral artery because it is an artery which pulsates. So after that, you move 1 to 2 centimeter inferior to this position, and you locate the femoral artery, which is medial to it. So it is recommended for you to do ultrasound to view the correct position. Next. So if you use an ultrasound guidance, you can visualize the dimension and position of the femoral vein. Make sure when you use ultrasound, you keep the ultrasound device in a sterile glove and compress the vessels with this ultrasound, and the vein will become collapsed with the tip of the needle can see clearly while the artery is still pulsating. Next. The procedure, basically you position the patient, clean the inguinal region, you infiltrate lidocaine with NS, and you palpate the landmark of femoral vein as I mentioned before. Okay, next. So in central line, you use the technique, Sildinger technique. Basically, it's the same for the PICC. So as you aspirate the blood, you disconnect the syringe from the needle as in step 2. And then in step 3, you insert the guide wire. Okay, let's look more closely at the next slide. When you insert the guide wire, now you want to remove the needle by maintaining the position of the guide wire. And then you take a scalpel, make an incision while avoiding the guide wire. Okay, next. When you make the incision, insert the dilator over the guide wire. You advance slowly. So after that, you remove the dilator while maintaining the guide wire position, and you insert the central catheter. So when the central catheter is at the suitable position, you remove the guide wire and secure the catheter with suture and also dressing. Okay, next. So the advantage of femoral vein is, first, it does not interfere with procedures located at your neck, your head, and it leaves the patient neck free of device. The disadvantage in femoral nerve, basically the patient is a child, so it is relatively a dirty area, and it can be challenging to place a pulmonary artery catheter through a femoral venous catheter. Okay, the complication is during catheter placement and also after the catheter placement. So during, you can have the patient bleeding, hematoma, air embolus, catheter embolus, and also arteriovenous fistula. After the catheter is placement, the child is at risk of infection, swelling at the lower extremity, deep vein thrombosis, catheter damage, knotting, or malposition. The last part is jugular vein. This location is at your neck, and it is one of the alternative to femoral venous catheterization. Next. So the indication is for those who have the inability to obtain peripheral venous access or intraosseous infusion. They can also do or insert the IV infusion like PICC and also femoral vein. The contraindication, we can divide into absolute and relative. So for absolute, do not do in patients who have thrombosis, infection at the insertion site. And also for the relative, do not do if the patient is uncooperative, have coagulopathy, anatomical distortion, and also superior vena cava syndrome and cardiorespiratory insufficiency. Now, the important part is the landmark. So jugular vein is located at your neck. Specifically, as you can see in this picture, we are interested in the internal jugular vein. So I highlighted that the internal jugular vein is located between your sternocleidomastoid muscle, and specifically it is lateral to the common carotid artery. All right, let's see the procedure. So the procedure is similar, but the one I would like to highlight is, first, we prepare the equipment. We clean the area with antiseptic and we position. This position is quite different from the previous procedure. The position, you must position the patient in Trendelenburg position, not Trendelenburg gait, but Trendelenburg position, in which, as you can see in this picture, the head is slightly lowered compared to the feet. And then you turn the head slightly away from the site of cannulation because you want to see the sternocleidomastoid, the sternocleidomastoid. Okay, then you can identify your internal jugular vein. So after that, you insert the needle, the guide wire, followed by the central catheter. Last but not least, do imaging test to confirm your position. Okay, next. The advantage of jugular vein, it have minimal risk of pneumothorax, and the catheter are minimally affected by ambulation compared to femoral. Femoral cannulation, it is affected if the child is moving. So the disadvantage, it is not ideal for prolonged access, and there is a risk you puncture the carotid artery. So you must, and it is difficult also for patients, especially children, who have short neck. They may be uncomfortable. Okay, next. Last but not least, the complication of jugular vein is bleeding, hematoma, air embolus, catheter embolus, arteriovenous fistula, and also pneumothorax or hemothorax. Okay, that is all from me. Any question?
Saya Amira.
Yes.
I want to ask about PICC care. What do you mean by taking antibiotic if needed? Is it when we suspect any catheter-related infection or maybe some other situation?
For the antibiotic, if needed, if the patient is suspected to have infection, yes. For example, if they present with fever, because when we puncture a hole, the patient is at risk of the bacteria to come in at the site. So yes, but I'm not sure if it is done regularly for every patient. Do we need to give antibiotic?
Oh, the answer is no lah. You don't give antibiotic to all PICC insertion. The thing is with PICC insertion, sometimes many times it's actually a bit difficult. So when it's difficult, you need many punctures. So when you need many punctures, so that's why sometimes you give antibiotic lah. Okay. Any other question? Okay. Boleh. So yang penting ni with central line ni, you need to remember because it is a central line. It is direct to the dia ada permanent punya central line macam hemopod, macam Hickman, Broviac line. These are dia almost macam jugular vein, masuk through jugular vein tapi dia surgically inserted lah. Yang ni boleh tahan lama. Yang lain semua again the most important thing is actually sterility. We need to maintain sterility, make sure it is sterile baru dia akan safe lah. Especially untuk femoral line. So femoral line ni dia dekat dengan contohnya baby yang pakai diaper kan. So bila baby pakai diaper, bila tukar nappy apa semua, kalau dia BO, dia diarrhea kan. So sometimes boleh get contaminated. So that's the problem with femoral line. It's the easiest to access. The least in terms of needing skill, tapi the problem is a bit difficult to maintain sterility. Okay, alright. Proceed next. Ada berapa lagi presentation ni?
Ada 3.
3 lagi? Oh, sudah.
Okay, faster.
Okay, alright.
Alright. Bismillahirrahmanirrahim. My name is Fatiha. And now I'll be sharing with all of you about another way for central access, which is special in pediatric, which are umbilical artery and also umbilical vein catheterization. So as you can see in the picture below, the umbilical cord consists of one vein and also 2 arteries, and the location of vein is usually at the middle as compared to the arteries. The location is laterally and inferiorly at 5 and 7 o'clock. Okay, so indications for this catheter. For UAC, umbilical artery catheterization, it is indicated for frequent measurement of arterial blood gases or continuous blood pressure monitoring and also continuous infusion. As compared to umbilical vein catheterization is indicated for emergency venous access, such as in neonatal resuscitation or preterm babies, especially extremely low birth weight, because we need to because they require long-term parenteral nutrition, and also babies in shock because their peripheral vessel is vasoconstricted. Then also UVC also is indicated for certain management such as exchange transfusion in case of severe neonatal jaundice. All right. So for contraindication, both contraindication for UAC and UVC are quite similar, which are omphalitis, omphalocele, necrotizing enterocolitis, and peritonitis. And vascular compromise in infants is an additional contraindication for umbilical artery catheterization. All right, so before we proceed, we have to know how deeply we want to insert the catheter. So for UAC, umbilical artery catheterization, there are 2 positions, which is first one is high position and the other one is low position. But high position is preferred compared to low position. So we have to ensure that the catheter is located inside the abdominal aorta at the level of T6, between the level of T6 and T9. For venous catheter, we have to ensure that the catheter is inserted in the inferior vena cava at the level of around T9 to T10. Okay, so steps prior to procedure, we have to examine the infants, and before we proceed, we have to examine the infants to look for sign of vascular insufficiency. So we have to check the femoral pulses and also note any discoloration of skins. Basically to look the sign for vascular insufficiency, any cold peripheries, and also any bluish discoloration of the skin. And then we have to document the finding because we want to compare with post procedure. And then you also need to have assistant. You need extra hands to help you to carry out this procedure. After you obtain the consent from the parents, then you are now ready to prepare the patient. So this infant should be lying in supine position, and both their arms and leg should be secure because we want to avoid their movement. From the movement, we want to avoid the movement that might contaminate the sterile field. So these are the equipments that are needed in this procedure. So first one is UAC and UVC set, which contain of grapes, gauze, clamps, forceps, scissors, tray, and also a scalpel with blade, and the three-way stop cord, 5 syringe, 5 cc syringe, together with heparinized saline, and also the umbilical artery catheter. You have to choose the size appropriately according to the weight of the infants. So in term infants, the size is 5 French. All right. So UAC and UVC procedure. In this procedure, I show you the step to insert both UAC and also UVC together. So first one, firstly, you will start the step by preparing UAC and UVC set. Then you proceed with scrubbing and gowning properly, because this one is procedure is you need. This one is a sterile procedure. Then choose the correct size of UAC and UVC catheter, as I mentioned previously. All right. Then proceed to clean the umbilical and also the surrounding area. After that, you drape the area to maintain the sterile field. Next, you hold the umbilical stump gently. Do not tug. Jangan tegang sangat. And then cut the umbilical horizontally. After that, you will be able to visualize the presence of 2 arteries and also 1 vein. Okay, then use probe to dilate the artery. Then the place catheter to the desired distance. So what is the desired distance? It is the formula for umbilical artery catheterization. Catheter this is the formula, both weight in kilograms times 3 plus 9 plus thumb length in centimeter. This one is for high position, which is the preferred position. The second formula is for low position, however, is no longer recommended. So example I give here is, for example, this patient is 2 kilograms, you times 3, you get 6 plus 9, and then you plus thumb length. Let's say the thumb length is 5 centimeters, so you get 20 centimeters. So you should insert the catheter up to 20 centimeters. Okay. So how we want to know that the catheter is correctly placed? So first one, for artery catheter, we can observe visible arterial pulsation in this tube, and also you can also observe the features of the blood, which is bright red blood. And then after that, you have to check the circulation because you have to check the circulation. Such as examine the lower limb and also the buttock, and also look for any sign of ischemia. All right, now we want to insert the catheter, venous catheter. Okay, so we have to identify the umbilical vein, then use probe to dilate the vein, and then insert the catheter. So how long we want to insert the catheter? The formula is tak nampak. Macam mana nak tutup? Saya tak nampak. Okay. The formula is 0.5 times UAC, the length of artery catheter. So and then you plus 1 centimeter. Basically half length of artery catheter, then you plus 1. So for example, in our case, previous length of artery catheter is 20 centimeter, right? So 0.5 times 20, you got 10 centimeter, and then you plus 1 centimeter equals 11 centimeters. So for the length for umbilical venous catheter is 11 centimeter. So how to know that you already insert at the right place? So you can observe the blood flow is a bit sluggish, slow flow compared to artery, and then the features of blood is dark red blood. Okay, and then after you inserted both catheters, then you have to secure the catheter in place by suturing, and also double suture the place by placing a together. Next, clear all the equipment accordingly, clear the sharp waste and also the chemical waste accordingly, and connect the umbilical artery catheter to the probe, to the monitoring system, and also the waveform. Right, last one is you have to perform a chest and also abdominal X-ray to confirm the place of UAC and also UVC. So this one is UAC and UVC in chest and abdominal X-ray. Okay, so here are some problems that you may encounter during this procedure. So the first one is if the insertion of the catheter is easy, but you do not observe any blood return, then or you sense a pop from the artery, it could be the catheter is outside the outside the track where it should be, it could be you already perforated the artery. So what should we do? We remove the catheter and then reinsert again at another artery because we have two arteries, right? So reinsert at another artery. Next condition is presence of resistance. Sometimes when you insert the catheter, before the catheter enter into internal artery, the resistance around the bladder. So what you have to do is you can press gently around 30 seconds, or you can change the position of the infant from supine to a bit lateral position. And also you can, another condition is malposition of UVC, where UVC, you should insert UVC in inferior vena cava, but sometimes, unfortunately, you insert this catheter inside the portal system, or the catheter tip is terlipat, is folded. So what you should do is you pull out the catheter a bit, and then reinsert again, and reinsert by rotating the catheter. Sorry. Okay, so post-procedure care for umbilical artery catheterization, very importantly, you have to look for ischemic changes every 2 to 4 hourly. And then we have to infuse with heparinized saline continuously because we want to prevent any thrombotic events, and also note the catheter line marking every day to make sure the catheter is in place, and remove the catheter as soon as no longer required. And also umbilical vein catheter, consider removing after 5 to 7 days because we want to reduce the risk for thrombosis and also infection. All right, for complications for umbilical artery catheterization, first one is bleeding from accidental disconnection. That's why we have to secure the catheter and check the length every day, the marking every day. And then next complication is embolization of blood clot or air, and then thrombosis of aorta or iliac, femoral and obturator artery, which can lead to limb ischemia. And then thrombosis of renal artery, which can lead to renal failure and hypertension, thrombosis in mesenteric artery, which can lead to gut ischemia or necrotizing enterocolitis, and so vascular perforation, and last but not least, nosocomial infection. For umbilical vein catheter is what first one is infection, and then thromboembolic events in lungs, liver, and also system is infection. And then pericardial tamponade arrhythmia or hydrothorax is the catheter is not placed properly, and also what portal vein thrombosis and portal hypertensions. Right, and that's all from my part. Is there any questions? Doktor tak ada.
I'm listening. I'm listening.
Ah.
I just have nothing to add.
Doktor boleh proceed ke?
Proceed.
Okay, bismillah, Assalamualaikum. My name is Sabila. So insyaAllah I proceed with chest drainage. My internet connection is not stable, so if you can't hear me, please let me know, okay? Okay, next. Next. Okay. So what is the definition of chest drainage? Chest drainage is the insertion of a chest tube into the pleural cavity to drain air, blood, pus, or other fluids. Next. So we have two indications for chest drainage. The first one is for prolonged drainage of air or fluid from the pleural space. For example, in the condition of pneumothorax, hemothorax, hydrothorax, chylothorax, empyema, and pleural effusion. The next indication is for definitive treatment of tension pneumothorax after needle decompression. Next. Okay, these are the contraindication of chest drainage. We can divide it into two, absolute and relative. The need for thoracotomy is an absolute contraindication for chest drainage. The relative indications include bleeding diathesis, which is a condition whereby a patient have tendency to bleed or breathe easily. For example, if the patient is on anticoagulant therapy. The second one is the presence of adhesion, skin infection over the chest tube. Okay, next. Okay, so what are the equipments used for chest drainage? Okay, you can see in the picture on your right side, the equipments are sterile glove, mask and gown, sterile drapes or towels, local anesthetic, which is 1% lidocaine, the antiseptic, 2% chlorhexidine, needle, syringe, scalpel, scalpel, Kelly curve clamps, silk suture, chest tube of appropriate size, pleural drainage system, gauze dressing, and transparent occlusive dressing. Okay, next. Okay, the size for chest tube, the size of chest tube vary depends on its indication, whether want to use for traumatic or non-traumatic. So in this table, it shows the appropriate size of chest tube for non-traumatic indication. We use different size of chest tube. For adult, it's according to gender, while its group is according to the age group of the patient. For traumatic tube customization, we use the tube, and the appropriate is 36 for 240. The size of the tube needs to be appropriate for the viscosity and accumulation rate of material that it will be used to drain. And for traumatic size, because it will accommodate the
Tak dengar.
next slide. To begin the procedure, place the patient in supine position or at
Sabila tak dengar.
I think we lost the presenter. Ada lagi benda.
sorry. Oh, hello, dengar ke?
Sekarang ya.
Sekarang ya. Tadi sampai mana? Saya left. Okay. With the procedure, the patient in a supine position or at 45-degree angle to reduce the risk of diaphragm elevation and improper chest tube placement. And then abduct and externally rotate the arm of the patient's affected side so that the patient lies behind his or her head. So we can put a restraint or silk tape to secure the arm in this location. Okay, next. Okay, and now for chest tube insertion. The chest tube is inserted in the triangle of safety. So why triangle of safety is the preferred site because it minimizes the risk of injury to the internal organ and vascular structure. So the triangle of safety is bordered anteriorly by lateral edge of pectoralis major, laterally by anterior edge of latissimus dorsi, and also the mid-axillary line. You can see the picture below. And it is bordered inferiorly by line at the level of nipple, only at the costal space. That is the base of the axilla. So to help the landmarking, remember the triangle of safety should be approximately between 4th and 5th intercostal space and anterior axillary line. So how to locate the landmark is first, we localize the clavicle. Once we found the correct intercostal space, so we move our hand laterally towards the anterior axillary line and mark the point. The incision point is intercostal above the incision point. Okay, next. Okay, for the patient preparation, the patient intravenous oxygen should be available. We monitor the saturation with pulse oximetry and sensation of NCRC, and we need to explain the procedure to the patient. Okay, sorry. Okay, I'm sorry. Telah lagi. Tiha. Okay. Video tadi.
Up behind their head.
That is where video.
I'm Dr. Jess Mason, and this is a method for chest tube placement. Before you get started, make sure your patient's pain is well controlled and secure their arm up behind their head with tape or a restraint. I want to make sure this guy doesn't move. Once you're sterile, prep and drape a wide area to keep a large field visible throughout the entire procedure, from clavicle to costal margin, sternum to mid-axillary line. Then, you're going to palpate down to the 4th to 5th intercostal space in that anterior axillary line. That's the spot. Now let's go get our equipment set. Take the large Kelly clamp and clamp the tip of the tube. Some people alternatively will go through that distal hole. There's no right or wrong answer. Take the second Kelly clamp and clamp the other end of the tube to prevent fluids from gushing out. Now, let's anesthetize the skin. Make a wheel at the skin, and then you're going to aspirate as you insert the needle. You'll know when you get in the pleural space because you'll get a gush of air or fluid back in the syringe. Then you're going to inject liberally as you withdraw the needle. Give that a minute to take effect, and then you're going to make your skin incision. So take your 10 blade and make a nice long skin incision. And now we're going to bluntly dissect with our Kellys, the small Kellys. Remember, we're going one rib space up because there's a neurovascular bundle that sits at the inferior margin of every rib, and we want to avoid that. Hold the Kellys here so you don't accidentally insert them too far. And insert the Kellys. Now, if you're new at this, it takes more force than you might expect, and it really does feel like a pop. That was it. That's in. Spread the Kellys open to create a hole in the pleura and insert your finger. Withdraw the Kellys. Now, I want you to feel right now, in this moment, that you are in the pleural space. So feel the inside of the ribs, feel the lungs, feel for adhesions. That's in, for sure. Now we can take our chest tube, and we're going to insert it supero-posteriorly towards the apex. Guide it along your finger and insert it until the last hole is all the way in. Perfect. Now we're going to suture it in place. So get your O-silk, and remember, there's no proven superior method for suturing in a chest tube. Here's one method that I like. We're going to make a simple interrupted suture on one side, pull through so you have equal ends of suture on either side, and tie a surgeon's knot. This is your anchoring knot. Wrap the ends around the tube and tie. First, I use zero form. Next, I use gauze that I've pre-cut out. Now we're going to tape it in place. Now we're going to pinch the tape around the tube. Now we're going to connect our chest drain. Gracefully, cut the end off. Connect your tubing and remove the clamp. Get your X-ray and you're all done.
Okay. Carry it by yourself. The summary of the technique. Okay, next. To confirm the placement of the hole, the arrow in the thoracic cavity, and it is seen as an interruption in the white line of the chest tube. So it confirms that it is at the correct place. Okay, next. Okay, for complication, the complications are improper position, pneumothorax, bleeding from intercostal vessel, puncture of liver or spleen, infection, and laceration of the lung. Next. We need to monitor the function of the chest drainage. The first one is we look for presence of air leak. If air bubble are seen in this chamber, it could be from a bronchopleural fistula. The second one is we look for fluctuation of water in water seal chamber. If the fluid does not fluctuate, there may be a kink in the tube or a clot in the tubing. The third one is we need to monitor the amount and type of the drainage, the presence of crepitus, the patient comfort level or pain level, and the appearance of the insertion site or dressing. Okay, next. Dah habis. Okay, that's all from me. Thank you. Sorry, internet tak stable.
Did you talk about using Seldinger technique ke untuk chest drain tadi?
Uh, oh, tak include Doktor.
So chest drainage ni tadi yang Sabila mention ni is just the direct technique lah, ataupun the basically thoracostomy punya teknik ni. So open teknik, tapi dalam video tu that is for adult lah. Children kita tak buat macam tu. Kita tak sikit different lah, tapi tak apa, I think that's okay. Just have that understanding, I think that video is okay. So children kita tak buat specifically macam tu lah. Dia ada few teknik lagi. Contohnya macam in emergency setting, you tengah ventilate patient, you bagging kena high pressure, tiba-tiba dia punya saturation tak pick up. So sometimes the problem is you have already caused pneumothorax. Bila you bagging patient dengan high pressure, you ventilate patient dengan high pressure, sometimes among the complication is pneumothorax. So sometimes pneumothorax ni you tak sempat nak prepare, nak pasang chest drain proper. So what you can do is you can just put the needle lah, you can use sama ada cannula ataupun you can use butterfly tu. You just puncture at the upper left to second intercostal space. Anterior, you puncture dekat second intercostal space tu and you drain the air out lah. So that's one technique. The other technique is almost similar dengan direct punya teknik ni, yang thoracostomy punya teknik ni, tapi instead of using trocar tu, you buat Seldinger teknik. Seldinger teknik ni macam yang kita belajar tadi pasal central line, femoral line. Maknanya kita guna guide wire. So bila guna guide wire macam mana? Kita mana contohnya dekat sama safety punya triangle tu, safe triangle tu, you puncture dengan cannula ataupun needle yang besar. So you puncture, you akan nampak ada gush of air, you removekan needle dia, tolak sikit dia punya plastik catheter tu in, lepas tu you masukkan guide wire. Guide wire masuk, you removekan catheter tu, lepas tu you dilate dan you masukkan chest drain. You letak pigtail for example. So actually Seldinger technique ni is very easy. So Seldinger ni is just you insert any catheter using a guide wire. That is Seldinger technique. Okay. Alright, tak apalah, nanti bila you kerja nanti kita akan belajar. My MOs pun ramai tak erti guna Seldinger technique ni, so tak ada guna for you to know now lah. But what I can say is Seldinger technique is kacang gila-gila punya. It's so easy lah. Alright, fine. Proceed next.
So, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So, can you hear me? Hello?
Yes.
Okay, so let's proceed to the last procedure. So, lumbar puncture. So, I think you already know about the lumbar puncture a little bit because you passed the medical posting. So, just a fact. CSF fluid is a clear or colorless fluid. It is found in the subarachnoid space, in the spinal cord, and in the spinal cord. Produced by choroid plexus and cerebral vessel at rate of 500 ml per day. So it reabsorbs to the venous sinus blood, so it reabsorbs back via arachnoid granulation. So the choroid creates and arachnoid absorb. Production match the reabsorption, so total about total CSF fluid is about 130 ml for adult lah. Kalau if children or pediatrics a little bit lower than 100. So for adult around 130 ml, just 130 ml. So next. So what is for indication for this lumbar puncture? So firstly for diagnosis and also for therapeutic. So diagnosis and also therapeutic. So for example, diagnosis is if you suspect of CNS infection such as meningitis, encephalitis, and also syphilis. Also in subarachnoid hemorrhage, we suspect the subarachnoid hemorrhage and hydrocephalus. Also, we done in the MS, multiple sclerosis, also the Guillain-Barré syndrome to diagnose the disease. And then for infusion anesthetic, and also chemotherapy, and also contrast agent. We same procedure. And for treatment for idiopathic intracranial hypertension. So these are the common indication for LP lah. So next. So for contraindication, we firstly idiopathic, or we suspect the increased ICP. So if we suspect the increased ICP by the signs or symptom, so we must avoid the LP. So rational LP is increased ICP may cause ankle herniation. So that's why we avoid in the increased ICP. For an exception, therapeutic use of LP to reduce the ICP. So in case of increased ICP, we may do the LP to treat the problem. And we do the CT brain to investigate, to confirm. Okay, so next. So firstly, increase ICP. So secondly, is the bleeding tendency or bleeding diathesis. So you can read uncorrected coagulopathy, clotting defect on if the patient had on medication, on heparin or warfarin. So you must avoid this patient. So others is skin infection, abnormal respiratory pattern, hypertension with brady, acute spinal trauma, seizure, recent seizure within 30 minutes, and also inexperienced physician. Okay, next. So these are the contraindication. So basically the contraindication is bleeding tendency, infection, increased ICP. So we must avoid in this patient. So what is the site of the LP? So as you know, the spinal cord ends at the L1, L2, right? So in the pediatric may lower than that, in the L2, L3, or between that. So usually L1, L2, so the site is below than that. Usually in adult, we puncture at the L3, L4, or pediatric, we may puncture lower, L4 to L5. So basically, there is marking. So we palpate the posterior superior iliac crest. So we draw the line. So the line is indicate the L4 position. So this technique is may helpful. We palpate the posterior iliac crest at the back. So next. So that the site. So for the equipment, these are the equipment. Sponge, spinal needle. The size is depends on the patient. If the pediatric, we use the smaller one. Syringe, vial for lidocaine. So local NS. Also the manometer to measure the pressure of the pressure, and then collection vial, and then sterile glove, povidone for the cleaning solution. Next. So I think I provide the video. Okay, this is the equipment. So the size is depends on the age of the patient. So 1.5 for infant, and then larger in the older children. So depend on the age. So I provide you the video. So let's see the video first.
I'm Dr. Jess Mason, and we're going to show you how to do a lumbar puncture. You want to position your patient either in lateral recumbent or, as shown here, sitting upright. This patient prefers to sit upright. Now, Either way, you want to have them arch their back and flex at the hip, and that's going to increase the distance between the spinous processes so your needle can more easily fit through. If they're sitting up, you can have them rest their feet on a stool, and then they can rest their head and their arms maybe on a table in front of them. Now, you can also consider giving them a little bit of benzodiazepine to help them through the procedure. Let's take a look at the real procedure done by Dr. Jordan Harp. Whether the patient is upright or lateral recumbent like this patient, identify the landmarks by palpating the posterior superior iliac crest, and where they meet in the midline should be L4, which is good. That's below the termination of the spinal cord, and we don't want to poke the spinal cord, so place a mark at this level. Clean the skin with antiseptic solution, and drape the patient to give yourself a sterile field. Anesthetize the skin with a wheel and then the subcutaneous tissue in the tract that you're planning to pass the needle, and we hope we're right. We know we may have to redirect. While that anesthetic is taking effect, you can get ready, set your tubes up and your manometer if you're going to check an opening pressure. To set up the manometer, take the two pieces of tubing and connect them. That way you can measure pressures greater than 36 centimeters of water. Now we're going to get the three-way stopcock and connect it here. And your spinal needle will connect right here. Make sure the three-way stopcock is open to the spinal needle and to the manometer, so the fluid column can rise up the manometer. Once you're done measuring your pressure, you're going to turn that three-way stopcock so you collect the fluid from the column into your collection tube. Spinal needles come with a stylet in place. The bevel should be oriented longitudinally with the dural fibers. So if the patient is lateral, the bevel is up. And if the patient is upright, the bevel is to the side. Try to stay midline and imagine that you're aiming right towards the umbilicus or the umbilicus or the belly button. Your needle has to penetrate the supraspinous ligament, which connects the spinous the ligamentum flavum, which connects the lamina of the adjacent vertebrae. So in theory, 2 pops. In an average-sized patient, that needle is going to be inserted about 3/4 of the way. Might be a little farther than you think. Now, it's important as you advance the needle that you're checking frequently if you're in the spinal fluid, because you won't always feel that pop through the ligaments. So remove the stylet and check for spinal fluid, and then advance it a little further. And then remove the stylet and check for spinal fluid, and then advance it a little further. Remove the stylet. Now, if you're still not getting spinal fluid after a few tries, you can remove the needle, or you can pull it out just to the subcutaneous tissue, repalpate for your landmarks, and insert the needle again when you change angles just a little bit. Insert. And it looks like we're in right here. So I'm going to ask an assistant, Dr. Whitney Johnson, to come help me out at this point. If you wouldn't mind getting the manometer. And we will set this up right here. Would you hold the top for me? And you can see the fluid column starting to rise up the manometer to give us a pressure. Once we have our pressure measurement, we're now going to collect the spinal fluid from the manometer into our collection tube. So you turn the stopcock to open it up. And once it's drained out from the manometer, you can remove the manometer altogether and continue collecting your spinal fluid. This LP was pretty difficult, and we ended up having to sit him upright to get spinal fluid. Normal CSF is clear. Try to collect a few milliliters of spinal fluid in each tube for testing, and remember, don't aspirate spinal fluid. Replace the stylet before removing the needle.
So that's all about the procedure. So in summary, the procedure is starting from the position of the patient. We may position the patient either the lateral recumbent or sitting. And then we palpate the landmark for the LP, and then set up the equipment, prepare and also the drape. We give the anesthesia, and then puncture. After that we measure the pressure, and then we can collect the CSF. After collection, we must compress the site of the puncture. Okay, that's the summary of the procedure. So this is the tube that collection tube. There are 4: gram stain, glucose, protein, cell count, and also for special studies. And then clean bag and also the cover puncture site. So this is the table for the normal value. So normal color, the clear is colorless. The blood count is less than 5. So you may read after this about so basically the color is clear and in the normal color, normal condition. So next. So this is important. So we must differentiate between normal and also other problems such as bacterial infection, viral, and also SAH, also TB. So I think you are familiar with this. So the normal is clear color. Is bacteria when give the turbid color, viral clear, and also if the problem is SAH, saya not hemorrhage, so the color is bloody. So the protein is normal, 23 to 38. So in bacterial, will be increased in the protein, viral normal or decrease, and in SAH increase. So for glucose, normal glucose in the SSF is two-third of serum glucose. So we must get the blood glucose level first. So we compare between these two, CSF and also serum. So normally two-third of glucose. So if it may decrease in the bacterial infection, meningitis, so viral may be normal, SAH is normal. And then accordingly lah, negative, positive, negative. So this important interpretation for the CSF fluid. So next. So this similar, the numeric letter. So the lastly is the complication. So the most common complication after the procedure LP is the post LP headache, or we call it PDPH, post dural puncture headaches, PDPH. So its most common complication usually is benign and also begin after 1 day to 2 days after the procedure. So probable etiology is continued leakage of the CSF. So this is the mechanism why the patient having headache. So it's common. So it's usually bilateral or throbbing headache. So in especially if the patient in upright position. So we must advise the patient to lying down. And then it is usually self-limited. Usually resolved within 7 days. So others complication is such as back pain. Back pain is common. Bloody tap, infection at the site, and also hemorrhage if the patient having any coagulopathies or bleeding tendency. And then this is the last one is post-dural puncture cerebral herniation. This is rare. That's why we must investigate first the ICP, or we look at symptom of the increased ICP. So we want to prevent this complication. It's very rare. So next. So this is about the headache. So most common complication usually female, young age, lower BMI. So it is a bilateral headache, can last hours to weeks. The treatment, like I mentioned before, supine position for at least 2 hours. So we advise the patient to lying down, lying flat. So hydration and also caffeine. So prevention, can be avoided by this is the prevention during the procedure. So I think that's all. Any question about the lumbar puncture?
Fifi, dengar tak?
Yes.
May I know why lumbar puncture is contraindicated after a recent seizure? Is it because we are afraid that the patient might have another seizure?
Okay. I'm not sure about that.
The issue is, first, you are not sure whether there is any cerebral edema. Sometimes seizure, one of the complications is clearly it's absolutely contraindicated. Just that if you're not sure whether the patient will still have seizure or not, of course you don't know whether there's cerebral edema. One control the seizure first, then only you lumbar puncture. Jadi because you tak nak tengah-tengah buat LP tu, dia dapat patient dapat seizure. Okay, one question to the presenter. What's the problem with lumbar puncture in Malaysia?
Sorry, Doctor, can you repeat the question?
Any problem with doing lumbar puncture in Malaysia? Specifically in Malaysia. Ada problem tak?
The negative perception or negative perception?
Yes. What is it? Tell us.
It may cause CNS apa? It may cause the paralysis.
So there's a myth in Malaysia among Malays that if you do lumbar puncture, the child will become paralyzed. So this is a myth because this story cerita kata jadi lumpuh ni, jadi paralyzed ni, it's not present in Chinese, it's not present in Indian, it's not present in orang asli. It's only among Malay. But where does this story come from? No one knows. In other countries, they don't face the same problem. It's specific to Malaysian. This is one issue lah. Yeah. Okay. Alright. Any other questions? Clear? Faham? Boleh buat dah. Next time.
Doctor, I have a question.
Yep. Yes.
Regarding Seldinger technique, they use dilator. Is it true that the dilator usage before insertion of the central catheter to make a passage for the catheter itself? Because I'm quite confused why they use dilator.
Okay. Seldinger technique untuk long line, untuk thoracostomy, untuk chest drain kan. The one good thing with using Seldinger technique ni, you tak payah ambil scalpel untuk cut the skin. You tak payah ambil needle to cut the scalpel, blade to cut the skin tu. You tak payah suture extra, you tak payah, maknanya risk of leakage tu kurang, risk of dislodge pun kurang. You dah pangkan bila Seldinger technique ni, you puncture guna needle atau you guna cannula. Biasa mesti needle lah. You puncture dengan needle. Lepas tu you masukkan guide wire. Lepas tu lepas you masukkan wire, you remove the needle tu. Tinggal guide wire je. Guide wire tu dengan skin dia betul-betul elok-elok je, dia fit je. So tak ada leakage. Blood tak keluar, air pun tak keluar, anything tak keluar. Kalau you nak masukkan tube yang you nak masukkan, contoh you nak masuk central line, you nak masukkan PICC, you nak masukkan chest drain, kan? Dia tak boleh pass through the skin dengan dia soft tissue kat dalam tu. So that's why you need to pass through the dilator. What the dilator does is just to dilate the skin and tissue a bit. That's why you boleh masukkan dia punya catheter. That's the only reason. Bila you masukkan catheter tu nanti dia akan nice fit supaya dia struggle elok-elok je. So tak ada air, tak ada blood. Buang ni dah pop, dah tarik. Tak ada suture, tak ada apa suture lain.
Oh, thank you, Doctor.
Comfortable for the patient. Okay. Wah, kelima dah. So I think well, again, as I have said many times, this is not ideal lah. You as doctors, you should not learn this procedure by this method. This technique is, I don't know what's the name that I could give. I don't have any good name to give lah. But this is not the way how you learn procedure. But at least what we want from you is just for you to have an idea about what's going to happen. But what I hope from you is that when you become doctor, you need to work hard. There's no other way. Because you need to remember that we cannot give you the appropriate teaching that we should have given you. We cannot give you the appropriate experience that you should have experienced as medical students. And you guys are going to become doctors. And failure to learn properly can affect patients' life. And that life can be from your family, can be from other one's family, can be my family. There is no other way. Having good attitude is very important. Work hard. Doctors, you need to work hard. Masa junior kena work hard. Masa tua, belakang tak ada, betul tak ada, you have to ikhlas. Work smart is important, but as doctors, you need to work hard. Itu dia kena ingat. Alright. Lebih lagi. Fine, I think let's end our session with Dr. Ghaffar. Terima kasih.